Hi folks, it's Dr. Meade and welcome to another episode of the Dr. Meade Show. I'm at the PNC Field in Moosic, Pennsylvania, and it's great to be back in my hometown area. This field, I remember when it was the Lackawanna County Stadium, and the Montage Mountain was the Montage Ski Mountain in the mid-'80s and the late '80s. So it's amazing to see what this venue has become. You know, the desire of the people in northeastern Pennsylvania to make this a world-class venue is unbelievable. The ski mountain is year-round entertainment, zip lines, you know, water slides and skiing, and this is one of the best minor league stadiums in the country. So I'm happy to be here, and we are running a seminar on our rapid recovery outpatient total knee program that we think is going to revolutionize how total joints are done in this country. There's an expected 700% increase in total joints, 3,000% increase in outpatient joints. And we have this rapid recovery program that we apply to every patient, whether you're in the hospital or not. But it does allow for us to do a significant percent of these as outpatient, like Sue had. And Sue had her knee done as an outpatient. We'll talk to her in a second. In April, she's having another one done on Monday. So, you know, I was saying today, you know, we had 40% of our patients go home today and 60% will go home tomorrow. So that's what we're going to talk about tonight, along with an opioid sparing multimodal approach, which is the cornerstone of this approach. Narcotics are the bane of many patients' existence, but we figured out how to get rid of them or minimize them, but substitute them with other opioid medications that decrease their pain. So with that, you know, introduction, I'm going to review with Sue. What was the history on your knee? How did your knee wear out at such an early age?
Well, I was diagnosed with osteoarthritis about 10 years ago, and over the last 5 years have had excessive pain and discomfort, and it really limited my ability to do common functions. So I decided to do the surgery with Dr. Meade.
What options did you exhaust before the surgery?
Well, I did over-the-counter medicines, weight loss, injections, cortisone shots, and none of those worked. They did work, but they were only temporary.
So those are all the things that you need to exhaust and try before you need surgery. And sometimes, you know, a cane or a brace can help, but, you know, how many people, you know, in their 40s are going to use a cane like you, Sue, you know? Yeah. So, but anyway, so let me talk about what we're going to talk about tonight in the seminar is the preoperative education, the joint class, and your preparation for the surgery. How was that, and what was your anticipation of pain? What were you looking at? What did you have fear, or what were you thinking about?
Initially, I really didn't know what to expect, but the seminar was very informative. Former patients were there to discuss their experiences. It was very helpful to listen to that information and to really know what was going to go on, the whole procedure. And it was a great experience. It really was. I felt very prepared, and I'm very happy with the results.
Which facility did we do it in?
Bethlehem.
In Bethlehem. And how long were you at the facility?
I was operated on at 6:30, and I was home by 2 o'clock that afternoon.
And you live how far away?
About an hour and a half.
So an hour and a half away. So that's pretty impressive. So, and part of the multimodal approach is the Tylenol, the anti-inflammatories, the baby aspirin, and you did all that?
I did.
You did all that?
Yes.
And usually, you know, it's hard to believe, but in the old days, it was, you know, narcotics for sometimes 6 weeks or 2 months afterwards. And now, you know, some people take no narcotics, but it's rare for someone to take them for, you know, more than a week. What was your experience with narcotics?
I only needed them for about 4 days, and then I was able to manage the pain with just Tylenol.
And we're going to talk about, you know, this opioid, this narcotic epidemic in the country, and how, you know, physicians are part of that. Insurance companies are part of that. We prescribe too many for too long. They populate the medical cabinet, you know, and you know, they're 6 of the top 10 drugs that high school seniors use. So we have to find safe ways to help patients relieve pain without narcotics and get insurance companies to pay for other non-narcotic medications. Those are the challenges that we're going to talk about tonight. So your neck surgery is scheduled for
Monday.
Monday, really 3 days from now. So I can't ask if you're looking forward to it, but
I am. Actually, I am. Yes, I know what to expect, and I know the outcome is going to be great.
Great. Well, you're a good trooper to be here and talk to us before the seminar, so enjoy it, and then hopefully we'll enjoy the game afterwards.
Thank you very much.
Thanks for coming. You got it. There's a lot of similarities with Coordinated Health because there was not an easy going for that ski place up here. It's been up and down. There were times when we didn't think it was going to survive, but you know what, look at it now. It's an amazing asset in northeastern Pennsylvania. It's year-round entertainment with water slides and zip cords. It's because the people here, they want it and they made it work. And the other venue that we're standing in is the stadium, PNC Stadium. And this stadium, we went to games when it was Lackawanna County Stadium, 1989 and 90, and it did not have an easy course. It didn't just pop out of the ground like this, but there's an interesting history that's related to the Lehigh Valley. The reason this place looks like it does today, because of the assets of the Lehigh Valley combined with the assets of the Wyoming Valley, and two of my patients and friends by the name of Lee Butz and Greg Butz of Butz Construction took their expertise in stadium building and stadium development, and they added it to the assets up here. And when the $40 million renovation was done 4 years ago, the combined assets of both valleys produced this. And so why is that like Coordinated Health? We started as a small orthopedic sports group in the late 80s. And let me tell you, Emil will tell you, this was not easy sailing. We had the same ups and downs as the ski place and this stadium. But you know what we are now? We're a healthcare network. We grew up just like this place. And you know what? We look at ourselves as almost the Butz equivalent of a certain talent skill that we have in the Lehigh Valley. And we have certain skills in our area. We are heavy and musculoskeletal, and if we add our assets to the people and the healthcare skills up here, we think we could create a valuable asset just like this stadium in healthcare. So that's what we're about. We're committed to northeastern Pennsylvania, and we could combine the assets of the Wyoming Valley and the Lehigh Valley just like they have in this stadium. We have innovation, patient education, patient engagement that Sue could talk about, different technology and procedures that were on the leading edge across the country. And we'll talk a little bit about our vision of the surgical facilities of the future. This is my little aspect of Coordinated Health I'll talk about. We have our specialized team. If you see us in Pittston or Allentown, these are the faces that are always with me. It's not always the same at a healthcare organization, but these 5 people have a sense of purpose. They're passionate. They're interested in your quality of life. When you come in, that's their function. And I have the ultimate trust in this group. If I didn't, I can't achieve all this on my own. These are professionals that are unbelievable. I call this the Meade door. And behind that, there's faces that you'll talk to called Molly and Joanne, Jitsa, Ruth, and Jenna. These are 10 people that are just on my team. So when you come in, you see my team, 10 people dedicated to you. We're just part of one cog in the coordinated health mechanism. There are hundreds of people behind my 10 that do this, operations, they do pre-certifications, they do the insurance work. But if you have a hip done, there's a hip team, there's a shoulder team, there's a sports team, there's a women's health team, cardiology team, and there's a bunch of other cogs that I don't have here, but they're all cohesive, specialized groups that trust each other. Are we perfect? We are not perfect, but I think we're a step in the right direction of the future of healthcare. We measure our outcomes. If I don't measure what I do, we kid ourselves and we say everybody does great. Everybody does not do great, but unless we measure our outcomes and we're part of a national registry that compares us to docs across the country, then we can't constantly improve. So here's the scope of the problem. 1 million total joints were done last year. It's expected to go through the roof in the next 10 years. It's supposed to increase by 700%, 3.5 million joints. But you know what? We can't afford it. And the biggest fear people have is pain. Historically, our studies show that 50% of the people had severe pain. And that just doesn't cause discomfort to the patient. But you know what it does? It delays rehab, it causes medical complications, it ultimately affects the function of the joint. And soon, 50% of the people are going to be less than 65. But look at this number. It's expected, outpatient total joints like Sue had, is expected to increase 3,000%. But if you look around our region and this region, you can't find anybody other than Coordinated Health doing outpatient total joints, but it's coming, and I'll show you why. We can't afford it. On the way up in the car, I was reading a Wall Street Journal today. By 2028, Medicare will spend more than they take in. That's in the next 10 years. So we can't afford to do joint replacements on Medicare-age people at the rate it's expanding. We can't do it in traditional hospital beds. It costs too much. There's too many medical errors. I'll show you how many medical errors there are. And right now, there are no outpatient codes for the medical groups. So, if Sue was in the medical age, she couldn't have it as an outpatient. But we're changing that. So we need to find cost-effective solutions. And again, we want to be part of that solution. We have lower cost, we have quality outcomes, our patients are happy, less errors. We have a lobbying group working. We have a lobbying group that we've hired in Washington working on changing those Medicare codes to decrease the hospital stays and to pay for these proven protocols and measure the outcomes. But look at the natural evolution. You folks have probably had some of these procedures. Arthroscopy, you assume that's an outpatient procedure. Anterior cruciate ligament reconstruction, shoulder, minimally invasive spine, even partial knee replacements along with gallbladders, appendix, hernias, they're all done as an outpatient. Why? Is because they were cost-driven, they had protocols, they're safer, and you expect it. So why not joint replacements? It's going there. It's there now in other parts of the country. We're sort of happy to bring it here. And people that say, you know what, I like the old way. I want to go to a hospital because it's safer. Well, you know what? Think again. When you look at it, even our wonderful hospital that has one of the lowest infection rates in the state, we like to get you out as quick as you can. Hospital errors are the third leading cause of death in the country. Did you know that? Behind cancer and heart disease. That's a crazy number. So if you don't want to die on an airplane, what do? You don't fly. So if you don't want to die in a hospital, you know what? You don't go there. This was a Division I athlete that had 8 surgeries, was 35 years old. So that patient has no need to be in a hospital. Of all the joint replacements, major studies show that 94% of all joint replacements have no complications. 94%. So why do we hospitalize people? We put them in the hospital because 6% of people have a complication. Well, can't we figure out which 6% are going to have a complication and which 94% aren't? But hospitals don't, so they put everybody in there. Does that happen in other industries? Let me show you an example. How about this industry? Do you recognize that? Airport. And look at all the people in line. And 99.99% of these people are not dangerous. They are not terrorists. But you know what? Because they don't know how to screen them any better, they have to treat everybody like they're a terrorist and screen them. But you know what this industry did? This industry figured out that maybe if we think ahead of time and ask a few questions, do some fingerprints and spend an hour, then we could figure out which people have felonies, which people, are illegal immigrants and are dangerous. And if you do that, you know what happens? You go through the quick lane. You're not in the long range. So they figured out, at least they're trying, but still the majority of people go through those long lines. It's just like the hospitals. The majority of people go in the hospitals. So why should you be a pre-check at the airport? Because it's quicker, it's a better experience, you travel with confidence, it's predictable, there's less anxiety, you make money or you save money because you're not there 2 hours ahead of time, you know you're going to get through, and you don't have to remove all your clothes. It's a bonus. So why would you join our rapid recovery program at Coordinated Health? We have expedited screening, it's a better experience, we educate people well ahead of that day of surgery. We eliminate a lot of testing if you don't need it. That 35-year-old Division I athlete didn't need a cardiology consult. She didn't need an echocardiogram and a cardiac catheterization. That costs a lot of money. And there's just a lot less anxiety, and you don't have to lay in bed for 3 days wearing those hospital gowns with nothing back here. And it's embarrassing. You don't need needle sticks every day, and you're not in severe pain by our multimodal approach. This is part of a national protocol that avoids narcotics. So we minimize side effects, Foley catheters, lower infection rate. You're not on heparin or Coumadin anymore because you're up walking. Your risk of blood clots go down. You immediately, ambulate. So this is what our rapid recovery program does. Once we figure it out, we have a tool. We ask questions like the TSA pre-check. And if you fit in, like today, 3 of my 7 patients went into the outpatient line. The other 4 are in the 23 hours. So right now, we have 95% of all of our joint replacement patients in 1 day or less, if you have a total knee on our team. We still need a couple 2-day stays for those 6% of people that have issues, and then some people have to go into rehab. But if that's the case, we have the rehab. So this is a whole different model of joint replacement. And here's the selection tool. There's 9 different comprehensive questions. That's just a summary. But if you look at it, only number 8 deals with your health. The Charleston Index asks a bunch of questions about health, diabetes, heart, etc. So really, to categorize you as an outpatient, and somebody might argue your age and BMI has something to do with health, but a lot of them deal with, are you motivated? Do you want this? Do you understand it? Did we teach you correctly? And if you do, we have a test to make sure you understand what multimodal pain approach, how you're going to treat any complications. Do you have a care partner at home? What's your home setup? Do you live with 8 cats and 4 dogs in the attic? Probably not a good patient for outpatient surgery. How close to a hospital for other issues? And did you pass preoperative therapy? How to get in and out of stairs on a low toilet? When you pass all those, we give you a score. If you hit between 30 and 35, you go into the outpatient arena. And if you're between 25 and 30, you're in the 23-hour stay, and so on down the line. But we have a process. It's not everybody goes in the hospital. We sort of figured out this screening process. And there's some other issues that if you have these, you might have to stay in the hospital, but they're not contraindications. We optimize it. If you're a smoker, then you're going to stop. If you're 100 pounds overweight, we're going to ask you to lose 50 pounds. If there's no one at home with you, we want a care partner. So we optimize that patient that wasn't a candidate. We had a patient he had kidney failure, he had COPD, and he had a history of an arrhythmia. We sent him to his cardiologist, his nephrologist, and his family doc, and we got him cleared and did him as an outpatient because we optimized those things beforehand. And so here's the key of this rapid recovery program. Get away from narcotics. Get away from narcotics. It's good for the patient, but I'm going to tell you why it's good for everybody else. You recognize that guy. We're almost used to a celebrity a week dying of a narcotic overdose. And a lot of the pain that they're presumably taking it for is orthopedic pain, hip and knee pain. And so in society, prescription drugs are used more than any other drug in the country. Each day, 44 people die from an overdose. It's the leading cause of accidental death exceeding car accidents. How many times you open the paper and you go, wow, there's a car accident up on 611 or Route 92 and somebody died, and you'll see those every day or 2 a day. Well, in the paper, if they said another person died of a narcotic prescription overdose, it would exceed the number of articles on car accidents because that's the numbers. But we don't see that, but it's the reality. And it exceeds heroin prescription doses. exceed heroin 2-to-1. And so our patients with total knees can be older. Their incidence of chronic pain is approaching 50%, and narcotics are now the most commonly prescribed class of drugs in the United States. I'll repeat that. Narcotics are the most common prescribed drug in the United States. It's wonderful historically for acute pain, but it's more commonly prescribed for chronic pain where there's very, very little medical evidence. And probably everybody here, if you go home, opens their medical cabinet, will have narcotics. I could assure you. From your oral surgeon, from some back pain, your family practice, you have it in your medical cabinet. And you know, if you have kids in high school or grandkids, they know it's in your medical cabinet. You know why? Because prescription drugs make 6 of the top 10 lists for high schoolers for abused drugs, and that's where they get it. So this is a terrible problem that, you know, we're responsible for. Opioids are widely diverted. There's a national epidemic, and you know where they come from? Most of them come from physician prescriptions. We write too many, and when we write them, we write too much volume, and they're diverted. Like the ESPN show, come on, man. Do you ever watch that show? Come on, man. Medical errors are the 3rd leading cause of death. So, you know, our Hippocratic Oath says do no harm. Look what we're doing. We're writing too many prescriptions. We're writing too much volume. And there's too many errors in a hospital. So we have to look in the mirror and stop doing this. But if we just stop it and say, tough luck, have a lot of pain, but we figured out how to avoid the pain, it's absolutely amazing. Go ahead. So, you know, historically, there was little discussion on pain. We do a knee replacement. The patients expected pain. Their neighbor had bad pain. I know it's going to hurt. I'm going to dread this, but I'm going to go through it. And you know what? We delegated it to anesthesia. We do an operation. There was no preemptive medicines given. You showed up in the recovery room. They said, Dr. Meade, Sue just arrived in the recovery room. She's having a lot of pain. And we go, that's not my problem. I'm on to the next case. Call anesthesia. All they do is give her more narcotics. They snooze her. She gets out of the recovery room. She goes up to the floor. The nurse calls and says her pain is back. The resident or the PA orders more narcotics. It's this downward spiral. Then they call and they say she's sick to her stomach. Give her some Zofran. And now she's itching because narcotics cause itchiness. Well, give her some Atarax. It's this downward spiral. They can't pee. Call the urologist, put a catheter in. And this is how we did things, you know, historically. So enter multimodal components. It took us decades to figure out that a lot of medicines that we take, that if you take too much of them have side effects, but not like narcotics. If we load you just a couple days ahead of time with Tylenol, nonsteroidals, COX-2 inhibitors, the Lyrica, the Neurontins, appropriate use of steroids, try to use spinals, short-acting spinals that last an hour or two instead of 8 hours, instead of general. And this has been a game changer for us, this longer-acting Novocaine. Unlike the dentist injects your mouth and it wears off in 2 hours, this wears off in 2 days. And so by then, it tapers off. And we're not, you know, against narcotics, but we don't think you need 200 of them. And so if you have breakthrough pain, but it's not used around the clock, we have new amino acids that we don't need transfusions for, hardly ever. You don't type and cross like the old days. Remember you had to donate blood and all that stuff? That all went away. And so, you know, here's the old way of a diagram that shows when we only had opioids, we'd make an incision and that pain signal would go right through the incision, through the knee, through the nerves, through the spinal cord until it hit the brain. And then we gave them narcotics. And then what happened is you got all these side effects. And the insurers don't seem to get it. We have our lobbyists trying to convince Medicare and the insurers that what should be common sense to us is not common sense to them. We're trying to convince them that outpatient total joints is here to stay, which it is, but we need, you know, updated coding. They have to decrease length of stays and embrace medicines instead of the opioids, and it will lower hospital-related side effects. Hospital-related side effects, 60% of the time, are due to narcotics. Can you imagine that? That's the statistics. And so there's a lot of blame to go around, and I don't quote Bernie Sanders too often up in this area, but I'm going to quote him today when he said, "People don't trust private health insurance companies for all the right reasons." And, you know, there's some root causes to this narcotic issue. The payers will pay for a prescription of 200 Percocet. And then next week, if you fill it again, they'll fill it again and fill it again and fill it again. But some of my patients, we send them home on Celebrex and Lyrica, they won't pay for it. So, you know, you look at this and they wonder why there's an opioid problem in the country. Physicians, I'm not trained in pain management. All we're trained is what our mentors did. Opioids were the gold standard. It was the path of least resistance. Let's give that patient 200 Percocets to go home because I don't want to get called at 2 in the morning. And then it populates their medical cabinet, which is propagating this problem. And we didn't know any other alternatives. A couple of years ago, orthopedic surgeons had no clue what Lyrica or Neurontin was. That was a pain management. And so our rapid recovery creates value. This optimal pain management program correlates with great patient results, same-day discharge or decreased length of stay, decreased cost, decreased medical errors, higher patient satisfaction, fewer discharge to rehab. The only people that go there are the people that need to. We're still going to have our 85-year-old people that live alone that need help. And we've done last year in our first year well over 100 with no readmissions, reoperations, or complications. And we're part of a national group that have the same results. So smaller incisions are good, but that's not the key. It's what you do under there. We don't cut tendons. We don't use a tourniquet anymore, which causes enormous pain. We don't dislocate the kneecap. We have a 10-step program to decrease infection. It's just not simply washing the knee with alcohol and giving them some antibiotics. We're changing the whole skill paradigm from 3 days to, we want our average stay to be 1 day where, like today, 3 patients went home in the morning, 4 will go home tomorrow. It's the exception that stays 2 days, and then we have some smaller folks that go to rehab. And so our goal is to have 95% of the people outpatient or one-night stay. They're independent immediately. They'll return to work whenever they can. No or minimal narcotics. It's here to stay at Coordinated Health. Significant growth is expected nationally, so we're happy to be at least bringing that service to northeastern Pennsylvania. It's safe, it's cost effective, and we're proud of Coordinated Health. We're the regional leaders in joint replacement. We do a lot of volume. We have a 5-star rating from CMS, and we love being here. Folks, thanks for joining us here at PNC Field in northeastern Pennsylvania. I hope you enjoyed the show. If you have any problems, we do have an office in northeastern Pennsylvania in Pittston. Please come in and see us, and have a great night.
From Coordinated Health, the top orthopedic surgeon in Pennsylvania, Dr. Tom Meade.